I think you can start the session, no?
Yes, even I think so. All the judges are here.
Yeah.
I think we should
Yeah,
start.
yeah. The first candidate is Akshay, Dr. Akshay.
Dr. Akshay, share your screen and
3950.
yes,
Yes, ma'am. Good afternoon, ma'am. I'll share the screen.
yes.
Yeah.
Good afternoon, everyone. My paper topic is assessment. Can I start?
Yeah, start.
Yes, yes.
Okay, my paper topic is assessment of color vision and contrast sensitivity in the type 2 diabetic mellitus. My chief author is Dr. Devika P. The financial disclosure is nil. The objective is to assess color vision and contrast sensitivity in type 2 diabetic mellitus patients and to correlate with stages of diabetic retinopathy and glycemic control. The introduction: diabetes mellitus is a common disease and is of two types, type 1 and type 2. Mostly in patients with type 2 diabetes, chances of developing diabetic retinopathy increases with the duration of the disease. The diabetic retinopathy changes have been classified using the ETDRS modification of the Early-House classification scheme. Patients with onset of diabetes set around 30 years or older with less than 5 years of duration and 40% of those on insulin and 25% of those not on any insulin treatment had retinopathy changes. These rates were observed to be increased to 84% and 53% respectively, with an increased diabetes duration of around 15 years. The American Diabetes Association suggested a control target for glycosylated hemoglobin of 7 gram per cent for diabetes and below which progression of microvascular changes are reduced. The color vision is the ability to distinguish between different colors as excited by lights of different wavelengths. The color vision test provides a very sensitive measure of a photopic function and its changes. Hence, any impairment in color perception indicates early degenerative processes in the retinas of the diabetics and often precedes changes in the visual acuity. Contrast sensitivity is the ability to perceive slight changes in luminance between regions which are not separated by definite borders. The retinal neurons perform a sensory function and define spatial resolution and contrast discrimination. For fine details and to discriminate contrast between the objects, macula has got a thickish ganglion cell layer and also a high number of horizontal neuronal connections. Altered retinal blood flow as a result of hyperglycemic causes changes in these neuronal function leading to decreased contrast sensitivity. Della Sala et al. And Bresnik et al. Have reported abnormalities in contrast sensitivity and color vision respectively with no or minimal diabetic retinopathy. The materials and method is the cross-sectional study including 32 patients in the age group above 40 years of both the genders. They were all patients reporting to Department of Ophthalmology. The study period is from October 2020 to August 2021. Place of study is outpatient department of AJ Institute of Medical Science and Research Center of Mangalore. The inclusion criteria, including adults of age from 40 above with both the gender and diagnosed with type 2 diabetic mellitus. With the exclusion criteria of congenital color blindness, psychiatric and mentally challenged, best corrected visual acuity less than 624, any pathology interfering with the fundus examination like significant cataract or a marked posterior subcapsular cataract and posterior capsular opacification, optic nerve pathology, glaucoma and prior ocular laser treatment, and any other retinal or ocular disease that may affect the color vision and contrast sensitivity. A detailed relevant history was noted and ocular evaluation was done along the relevant investigation, which include following like demographic detail and relevant systemic and ocular history and duration of diabetic mellitus and a systemic treatment taken for the control. Visual acuity was seen and pinhole vision and contrast sensitivity test done using a Pelly-Robson chart and color vision test using Ishihara color vision charts. Slit lamp examination was done and detailed posterior segment evaluation was done. and a lab investigation, latest HbA1c values were obtained for all the included patients to assess the glycemic control. The result study was conducted on 64 eyes of 32 patients, and the statistical tests were used were student Fisher exact test and the t-test. And in the result, we had seen the more of the patient or of above 60 years of age, and female predominance was noted, and the duration of diabetes was noted more commonly of 11 to 20 years. More patients were in that group, and the fundus examination, we had seen more patients of moderate NPDR in both eyes. When we compared contrast sensitivity to the duration of diabetic, we got a p-value of 0.077, which is a non value for the where we consider p-value of 0.0005. And but for the duration of diabetes and when compared to color vision, the p-value comes around 0.025, which is a significant value. And when we compare color vision to the fundus noted that the moderate NPDR patient has color vision abnormalities more, and the Fisher exact t-test was significant of p-value 0.22. And similarly to the contrast sensitivity, we can see there is a color vision abnormality seen without any diabetic retinopathy changes also, but a Fisher exact t-test of p-value 0.171, it is a not significant. And when we compared HbA1c values to the color vision and contrast sensitivity, we got a highly significant value with the t-test p-value of for color vision it is 0.000, and for contrast sensitivity we got 0.05, which is highly significant here. In the discussion in this study, we demonstrated that there is a significant correlation of color vision abnormalities to the severity of diabetic retinopathy and duration of diabetic mellitus and to the glycemic control with the help of HbA1c. And Green et al. Reported a color vision abnormality where correlates with the severity of diabetic retinopathy. This is consistent with our result. Our study demonstrated a significant correlation of contrast sensitivity abnormality to the glycemic control. But there is no significant correlation for the contrast sensitivity abnormality with the severity of diabetic retinopathy or the duration of diabetic mellitus. But in Della Sella et al. And Presnick et al. Have reported abnormality in contrast sensitivity and color vision respectively with no or minimal diabetic retinopathy. The conclusion of study is that it shows that there is a significant color vision abnormality seen with the severity of diabetic retinopathy and duration of diabetic mellitus. Also, there is a significant correlation with abnormality of color vision and contrast sensitivity with the glycemic control. Furthermore, the small sample size is the limitation of this study. Thank you.
Dr. Akshay,
Yes, sir.
is there any controls you have taken or just only diabetic patients?
No control, sir. Only diabetes.
Only diabetic patients.
Yes, sir.
What about the color vision and contrast sensitivity in well-controlled diabetic patients as compared to uncontrolled?
As we had seen in the sir, with the control of, I mean, if you take as HbA1c as the control group, sir, with the HbA1c mean value of 6.12, there was no color vision abnormality, but above 8.71 there was a color vision abnormality for the glycemic control uncontrolled patients.
But at the time of checking color vision and the contrast sensitivity, whether the sugar was normal or it is high?
No, sugar was high, sir, in 14 of patients.
Okay.
In 18 patients, it was normal.
Okay. Okay, thank you.
Thank you, sir.
Dr. Akshay, have you excluded the patients of DME who are having good vision like that? I mean, have you done OCT on these patients? Those who are having minimal DME, 1 or 2 cystoid spaces in the fovea. Have you excluded those patients? Have you done OCT on these patients or no? Severe NPDR?
OCT was not done.
OCT was not done.
Not done. But poor vision, like best
No,
corrective
no,
visual acuity.
we do get some patients with good vision, but
Yeah.
they'll be having some macular changes. A
Yeah.
few cystoid spaces can be there with 6/9 vision also. So have
Yeah.
you included them or excluded?
OCT was not done. So
And there is an association between diabetic macular edema and color vision defect. Correlation is there. So you should have noted how many had
diabetic macular edema.
macular edema.
Okay.
And which test is ideal? Color vision test is ideal for testing color vision defects in diabetic patients.
The 100 test was the ideal.
Yes,
The
which is the
compact.
most common color vision defect noted in diabetics? Like which color, red, green or blue, yellow defect?
It's usually red green.
No. The other studies have seen noted blue yellow defect, and with this Ishihara's chart, you cannot diagnose it. So,
Okay.
so ideally, that test would have been better.
Okay.
Farnsworth Munsell test would have been
Yeah.
better. Okay. Okay. Shall we move on to the next presentation?
Yes, yes.
Yeah, next one is Dr. Sayeda Amina.
Hello.
Yeah, continue.
Good morning, sir. Good morning, everyone. Hello.
Yeah, continue.
My topic is ocular manifestations in pregnancy-induced hypertension. My chief author is Dr. Lakshmi ma'am. Coming to its introduction part, hypertensive disorders in pregnancy considered to be the major risk factor and an important cause related to maternal morbidity and mortality. Disease mechanism of PIH might affect almost every organ system, including ophthalmologic parameters. Changes observed in retinal vasculature may be correlated to the severity of hypertension. Coming to materials and methods, it is a hospital-based cross-sectional study was done in Department of St. in Bellary over a period of 9 months. This is from Jan 2021 to September 2021 for patients who had been referred for ophthalmic examination. In that, 50 patients diagnosed with preeclampsia and eclampsia were studied. Detailed history and examination was done, including blood pressure. Anterior segment examination was carried out with torchlight, and pupils were dilated with tropicazide plus eye drops, that is tropicamide 0.8% and phenylephrine 5%, and fundus examination was carried out using indirect ophthalmoscope. Inclusion criteria: all patients with preeclampsia and eclampsia. Exclusion criteria was chronic hypertensive patients.
Excuse me, sorry to interrupt you, Dr. Saida. Your slides are not moving.
Not moving, ma'am.
Yeah.
I think you have to go to full screen presentation view.
Yeah, now enlarge
It's
it.
visible. It's visible now, ma'am.
Now it's visible. Make it full screen.
Make it full screen.
It was full screen only, ma'am, last time.
But here we are
Go
not.
to
getting.
presentation view.
It's not coming, ma'am, that time.
Okay, can present that. Now the slides are moving.
Exclusion criteria was chronic hypertensive patients, pre-existing renal diseases, diabetes mellitus, and ocular pathologies which hinders the fundus examination, that is cataract or any opacities in the cornea. Coming to the total patients we have selected 50. In that, patients with fundus findings were blurring of vision presented with 7 patients presented with blurring of vision and 4 patients presented with headache, and patients with no complaints were 21. And according to Keith Wagner's classification, we have classified it as grade 1 hypertensive retinopathy, which was seen in among 12 patients, and grade 2 hypertensive retinopathy among 5 patients, and grade 3 hypertensive retinopathy in 4 patients, grade 4 in 7. Macular edema was seen in 3 patients, and serious retinal detachment was seen in 2 patients. Coming to analysis and results, patients with ocular complaints were 12, that is 36% among all the study subjects, and patients without ocular complaints were 21%, 21 patients, that is 63.60%. That is, patients without ocular complaints were more than the patients with ocular complaints. And blurring of vision was seen in 7 patients, that is 58.33% among all the study subjects, and headache were in 5 patients, that is 41.66%. And normal patients were 17, 34%, and with fundus spanning were 33 patients, that is 66%. Grade 1 hypertensive retinopathy was seen in 12 patients, that is 36.36%, which is the most common fundus finding we have seen. And grade 2 hypertensive retinopathy in 5 patients, that is 15% of the study subjects. Grade 3 was seen in 4 patients, 12% of the study subjects. And grade 4 hypertensive retinopathy in 7 patients, that is 21.21%. Macular edema in 3 patients, that is 9%, and serous retinal detachment in 2 patients, that is 6% of the study subjects. And BP 140 by 90 was seen in 13 patients, that is 26%, and more than 140 by 90 in 37 patients, that is 74% of the study subjects. Coming to discussion, fundus changes were seen in 66% of total study subjects. Among them, 36% had the ocular complaints. Among them, blurring of vision was the most common ocular complaints we have found, and 63.63% had no ocular complaints. 36.36% having grade 1 hypertensive retinopathy changes, and systolic and diastolic blood pressure were higher in those with fundus changes compared to those without fundus changes. Coming to conclusion, among PIH patients, segmental arterial narrowing was the most common fundus finding we have seen, and fundus changes were more commonly seen in patients who don't have any visual complaints. So increasing blood pressure is an indication for frequent screening of retina and retinal changes hypertension to detect early changes, as these changes help as a guideline for termination of pregnancy, as they may reflect the similar ischemic changes in the placenta. Thank you.
So what are the causes for that blurring of vision which you have noted in most of the patients?
Blurring of vision causes was the retinal detachment, macular edema, and grade 4 hypertensive retinopathy. That's why patients with complaints were less. That's why patients who are having complaints were lesser than the patients who don't have complaints.
So it was just a blurring of vision, or there is a gross decrease in vision?
No, gross decrease in vision only, sir. Actually, the patient was complaining
Well,
that blurring.
Only gross decrease will be seen only in serious retinal detachment. But otherwise, usually patients will have almost near normal vision. Or they have associated refractive error, which is aggravated.
Actually, for refractive error, we have not checked because it has been done in website examination for only.
Okay. Okay.
Yes, sir. That's why only vision I have checked.
Okay.
Website I have checked. That's it.
Okay. Any other questions?
No, sir.
No, sir.
Okay, can continue with the next one.
Yeah.
Dr. Monesh.
Yes, sir.
Yeah.
Yes. So shall I share the screen, sir?
Yeah.
Sir, am I visible, sir?
Yeah. Enlarge the slide.
Sir, is it completely visible, sir?
Yeah, visible, but make it full screen.
Yes, sir. Full screen. I've done it.
Okay, but it's not coming.
Sir, is it visible?
Okay. Yeah, it's visible. Continue. Slides.
Good afternoon, everyone. Myself, Monish, with a study to analyze structural changes in retina by optical coherence tomography in diabetic patients. My chief author is Dr. N. Vijay, and I thank Dr. G. Pawan and Yogesh RP and Dr. Persappa. And introduction: diabetic retinopathy is a damage to the retina caused by the complications of diabetes mellitus, which can eventually lead to
The
blindness.
slides is not moving. Your slides are not moving. Yeah, now it's fine.
Okay, sir. Introduction. Diabetic retinopathy is a damage to retina caused by complications of diabetes mellitus, which can eventually lead to blindness. Diabetic retinopathy remains the commonest cause of blindness in the working age population of the developed world. Effective treatment is available if the condition is detected early before the visual symptoms occur. The need for a comprehensive diabetic retinopathy screening program has been well organized, and it is now feasible with the use of optical coherence tomography. The materials and methods for it is a cross-sectional hospital-based study which is conducted from Jan 2021 to August 2021 with 25 number of patients attending the Department of Ophthalmology. And the included criteria for the study were the patients of the age more than 21 years and NPDR and PDR diagnosed with a slit lamp, and the diabetes mellitus were diabetes diagnostic criteria which was prescribed, which was laid down by the rules of World Health Organization, and the patients under medical treatment by a physician or an endocrinologist. The exclusion criteria for the study is a patient with diabetic retinopathy who had undergone any form of treatment, whether it could be grid laser or PRP laser. Patients who were associated with hypertension and any media opacities were excluded from the study. And the clinical evaluation eliciting proper appropriate history and systemic evaluation was done. Visual acuity was charted by using Snell's chart. Anterior and posterior segment evaluation was done. Estimations of the blood sugars. Optical coherence tomography were done for all the patients who were included in the study. According studies and the results the analysis and the results of a study, 24% of the patients who were included in the study showed the age range of between 41 to 60 years were more in number, which was 24%. Um, and the duration of the diabetes, uh, the patients were 56% who were diagnosed with diabetes were in the range of 5 to 10 years of diagnosis of diabetes mellitus. And the type of diabetes mellitus in our study, there were type 2 diabetes on oral hypoglycemic drugs were 64%, and type 2 diabetes mellitus on insulin were 20%, and type 1 diabetes showed 16%. And the type of diabetic retinopathy in our study, most of them were moderate NPDR with 44%, and 24% showed severe NPDR, and 20% with polycystic diabetic retinopathy, and 12% showed mild NPDR. And the visual acuity in our study, the most of the visual acuity in the study were ranging from 4 by 60 to 6 by 18, which was equally distributed 36%, 36%. And in our study, the diabetic retinopathy with macular edema were 44% of the patients. The retinal foveal thickness in diabetic macular edema patient were ranging from 351 to 500, which showed almost 63% of the patient micrometers. And the discussion, the age in our study, the most of the patients were commonly in between the age of 41 to 60 years, were 48% who showed the changes. Males were more affected. The duration and type of diabetes, the range of 5 to 10 years, were 50%, and type 2 diabetes mellitus on oral hypoglycemic drugs were more common. Type of the diabetic retinopathy, moderate NPDR was more common in our study. The most common OCT finding was cystoid macular edema. The central foveal thickness, according to our study, were ranging from 351 to 500. Prognostic factors, the early detection uh, of the thickness of the central foveal thickness could be helpful for the regular follow-up and then a plan of treatment of the patient, which would which would provide the patient with good treatment by us. Conclusion: the central macular thickness was measured using OCT, and the status of the photoreceptor layer significantly provided an objective guideline for predicting the visual improvement in eyes with diabetic mellitus. The foveal thickness is a strong independent predictor for clinical significant macular edema. That foveal thickness more than 180 micrometer measured by OCT may be helpful for the early detection of macular thickening and may be indicator for a closer follow-up of the patient with diabetes mellitus. Optical coherence is a non-invasive which allows not only for the qualitative diagnosis of diabetic macular edema, but also for the quantitative assessment of diabetic macular. Thank you.
Dr. Maunesh, you have just told about the macular thickness, central macular thickness. What are the other findings seen in patients with diabetic retinopathy,
Ma'am,
especially in
ma'am,
the diabetic macular edema patients?
Ma'am, basically the study was to see, according to the foveal thickness or retinal thickness, how is the visual improvement, and our study is basically to see like whether if we only to screen if the thickness is in ranging from 150, we can ask them for a closer follow-up according to the ETDRS classification and all. Ma'am. It was only for a cross-sectional study, ma'am. Only the thickness as a prognostic factor, foveal thickness. That is the only thing.
Okay. Because the title of your study says structural changes, no? So you should be including all other changes also, not just the thickness.
Okay. But other stages based on the OCT were also done, no? But I didn't mention it because the basic
What
for
are,
this
what are those changes?
It's a
There is
cystoid
one.
macular edema.
Yes.
Hmm.
Go ahead.
Vitreous macular traction and posterior hyaloid based on the OCT finding form. These are all OCT changes. Vitreous macular traction, cystoid macular edema, and posterior hyaloid and taut hyaloid traction.
There's one classification of DME based on OCT, and there are 6 types in that.
Based on OCTs.
Yeah, OCT classification is there.
So, CSME, serous macular
OCT
posterior
classification.
hyaloid.
Okay, any other questions?
No,
Was
sir.
was there any difference between NPDR cases with macular edema and PDR cases with macular edema? The amount of edema what you have seen.
No, the visual acuity persisted to be same. Just the follow-up treatment was done. So, follow-up as in like only what could be the plan of treatment and the visual outcomes were studied, ma'am. Not any interventional and changes. Visual acuity
What type of
remains
macular edema have you included mainly? Have you included all sorts of macular edema in this?
yes, yes,
For
ma'am.
example,
Yes.
SSRD, CME, spongiform edema. Have you classified
Yes.
again in this?
No, ma'am. I have not classified on this, ma'am, on the studies. The sponge form, taut form, and posterior highlight form, they were not included, ma'am, in this. Based on the OCT, were not included.
Okay, thank you.
Okay, the next presenter, Dr. Nivarani.
Good morning, sir. Can I share my screen, sir?
Yeah, start.
So is my screen visible, sir?
Yeah.
Good afternoon, everyone. I'm Dr. Nivarani. I would like to thank the organizing committee for providing this platform to present my research paper on severity of diabetic retinopathy with duration of type 2 diabetes mellitus. Introduction. Diabetes mellitus is one of the most common metabolic disease globally and hence one of the most challenging health concerns in modern era. Diabetic retinopathy is a very common, potentially preventable long-term microvascular complication of diabetes mellitus and a leading cause of visual disability and blindness. Almost all patients with type 1 diabetes mellitus and more than 60% of patients with type 2 diabetes mellitus will develop some degree of retinopathy after a 20-year history of diabetes. Patients with diabetic retinopathy are 25 times more likely to become blind than non-diabetics, according to New York National Society to Prevent Blindness 1980. Aim of the study is to study severity of diabetic retinopathy with duration of type 2 diabetes mellitus and to study severity of diabetic retinopathy with HbA1c in type 2 diabetes mellitus. Source of data: all patients with clinically diagnosed type 2 diabetes mellitus attending ophthalmology OPD. Materials and method. This study was conducted over a period of 1 year from September 2020 to August 2021, and 50 diagnosed cases of type 2 diabetes mellitus attending ophthalmology OPD were selected and enrolled in the study. The cases were non-selective with regards to age, gender, ethnic origin, and occupation. All patients underwent detailed ocular examination, which included visual acuity, along with slit lamp examination to visualize the anterior segment of both the eyes. Intraocular pressure was measured and documented for both eyes. Fundus examination of both eyes was done, and any changes attributable to diabetes were documented and graded according to early treatment diabetic retinopathy study. Results. Table 1, general characteristics of participants. The mean age seen in this study was 58.52 plus minus 2.3 years. Gender, male. In the study, 64% were male, that is 32 patients, and 36% were female, that is 18 patients. HbA1c level, normal less than 6.5 was seen in 38%, that is 19 patients, and abnormal, which is more than 6.5, seen in 62%, that is 31 patients. Mean duration of diabetes mellitus was 8.2 plus minus 1.6 years. Figure number 1, duration of diabetes status. 0 to 5 years history of diabetes mellitus was observed in 22 patients, 6 to 10 years in 16 patients, 11 to 15 years in 8 patients, 16 to 20 years in 3 patients. Figure number 2, grades of diabetic retinopathy. 30% of the patients showed no diabetic retinopathy, 36% showed mild NPDR, 22% showed moderate NPDR, 6% showed severe NPDR, and 6% showed PDR. Table 2, association of grades of diabetic retinopathy with duration of diabetes mellitus. Duration of diabetes mellitus 0 to 5 years. 11 patients showed no diabetic retinopathy, 8 patients with mild NPDR, 3 with moderate NPDR, 0 severe NPDR, and 0 PDR. 6 to 10 years, 4 with no diabetic retinopathy, 8 mild NPDR, 3 moderate NPDR, 1 severe NPDR, and 0 PDR. 11 to 15 years, 0 no diabetic retinopathy, 1 with mild NPDR, 4 with moderate non-proliferative diabetic retinopathy, 0 severe NPDR, and 1 PDR. In 16 to 20 years, 0 and no NPDR, no PDR, 1 with mild NPDR, 1 with moderate NPDR, 0 severe NPDR, and 1 PDR. More than 21 years, 0 no diabetic retinopathy, 0 mild NPDR, 0 moderate NPDR, 0 severe NPDR, and 1 PDR. Total, 15 patients showed no diabetic retinopathy, 18 patients showed mild NPDR, 11 patients showed moderate NPDR, 3 patients showed severe NPDR, and 3 patients showed PDR. P-value was less than 0.001 and it was significant. Table number 3, association of grades of diabetic retinopathy with HbA1c. HbA1c less than 6.5, that is good glycemic control. 13 patients had no diabetic retinopathy, 5 had mild NPDR, 1 moderate NPDR, 0 severe NPDR, and 0 PDR. HbA1c of 6.5 to 8.5 with a fair glycemic control. 4 patients had no diabetic retinopathy changes, 7 mild NPDR, 3 moderate NPDR, 0 severe NPDR, and 0 PDR. HbA1c more than 8.5, that is poor glycemic control. 1 patient had no diabetic retinopathy changes, 3 with mild NPDR, 7 with moderate NPDR, 3 with severe NPDR, and 3 with PDR. Discussion. A total of 50 patients comprising of 32 males, that is 64%, and 18 females, 36%, were studied in the with the mean age being 58.5 plus minus 2.3 years. This was correlating with a study done by Nivedita H. et al. And Gadkari S.S. et al., which revealed the highest prevalence of diabetic patients in the age group of 51 to 60 years and 55 to 64 years respectively. In our study, we found that patients having a good glycemic control, that is HbA1c less than 6.5, had lower prevalence of diabetic retinopathy with 31.5% as compared to those having fair control with HbA1c from 6.5 to 8.5 with 71.4% and poor control HbA1c more than 8.5 with 94.1% prevalence of diabetic retinopathy. Similar to our study, Dipasha S. et al. And Manavet et al. Also found a significant association between HbA1c level and diabetic retinopathy. Whereas in a study conducted by Nagashri D. et al., it showed no significant association between HbA1c level and diabetic retinopathy. Based on chi-square test, this study shows that there is significant association between duration of diabetes and severity of diabetic retinopathy with p-value less than 0.001%. The result is consistent with the study done by Abhishek et al. And Fath et al., which showed a significant relationship between duration of diabetes and the severity of diabetic retinopathy. However, this result is different from the study done by Intan Lamai et al., which showed there is no association between diabetes duration with the severity of diabetic retinopathy. Conclusion. The result of the study statistically indicates that there is association between duration of diabetes with the severity of diabetic retinopathy. This result also concludes that the HbA1c level increases, diabetic retinopathy also increases both in terms of frequency and severity. Hence, it is advisable to include HbA1c as a screening tool in the evaluation of diabetic mellitus and as a predictor for the development of diabetic retinopathy. These are my references. Thank you.
Dr. Nivarani,
Yes, ma'am.
have you done a head-on comparison between HbA1c and the duration of diabetes? For example, if you have a high HbA1c level, say 9, versus a 5-year-old diabetic, we do see PDR cases. Have you done a comparison between the amount of HbA1c and the duration of diabetes?
Ma'am, that I haven't done. I have only done HbA1c level with the severity of diabetic retinopathy only, ma'am.
Okay.
Yes, sir.
And that 16 to 20 years and also more than 21 years, the number of patients are less. The severity is less. So is
Yes,
it because of number of patients are less, or they had very good control?
So it could be one of the reason because our sample size is little small, so that could be one of the limitation also. So, but otherwise, those people are having more severe grades of diabetic retinopathy, maybe because of more exposure of high levels of HbA1c, sir, for longer period of time.
Okay, thank you. Any other questions?
No, sir.
No, sir.
Okay, we can go to next presenter, Dr. Parvati.
Good afternoon, sir.
Yeah. Good afternoon.
Shall I share my slide?
Yeah.
Is it visible?
Yeah. Continue.
I'll put it on for some time, then I'll come back.
Good afternoon. My topic is on effect of high myopia on macular thickness using OCT and observational study. My co-author is Dr. Pradeep Evi. There is no financial interest. Introduction. Myopia is the commonest refractive error encountered in the OPD among young adults. In high myopic patients, scleral ectasias are relatively frequent and involve the posterior pole of the eye, leading to poor visual prognosis in adult life. OCT is a non-invasive high-resolution imaging technique of the retina and optic nerve head. With the advent of the modern imaging technologies, the measurement of the retinal thickness has been made possible in vivo, and the relationship between high myopia and retinal thickness has been made. So my slide is not moving. Excuse me, sir. Hello. Sir, am I
Yeah,
audible?
yeah.
Hello. Sir, is it, are you able to see the slides now, sir?
Yeah. Continue.
Okay, sir. Okay. Introduction. Myopia is the commonest refractive error encountered in the OPD among young adults. In high myopia patients, scleral ectasias are relatively frequent and involve the posterior pole of the eye, leading to poor visual prognosis in adult life. OCT is a non-invasive high-resolution imaging technique of the retina and optic nerve head. With the advent of the modern imaging technologies, the measurement of the retinal thickness has been made possible in vivo, and a relationship between high myopia and retinal thickness has been made. Objectives: to describe the macular thickness in high myopic patients using OCT in terms of the central foveal, parafoveal, and the perifoveal retinal thickness in myopic young adults with respect to their age, sex, and spherical equivalence of refraction. Materials. Type of study: it's an observational study conducted over a period of 6 months. The total number of study subjects were 20, and inclusion criteria are young adults between 18 to 30 years with a spherical equivalent of more than or equal to -6 diopters and intraocular pressure between 10 to 21 millimeters of mercury. Exclusion criteria: presence of any other systemic diseases and other ophthalmic diseases like glaucoma, uveitis, media opacities, and retinal diseases, and subjects who refuse consent for the study. Methods: 20 high myopic eyes were included in the study. All subjects underwent a full ophthalmic examination, including BCVA, cycloplegic refraction, intraocular pressure using Goldmann applanation tonometer, and dilated fundus examinations. Pupillary dilation was achieved by 0.5% tropicamide. Ethical approval for the study was obtained from the institutional ethical committee. Written informed consent was obtained from the study subjects. Macular retinal thickness was measured by Zeiss Cirrus 6000 to 100 kHz OCT imaging system, and the mean retinal thickness was determined as defined by the ETDRS using a macular map. This is a macular map which was used for the study. Variables are expressed as mean plus or minus standard deviation, and data analysis was performed using SPSS version 220. Students' t-test was used to analyze the differences in macular thickness between male and female subjects, whereas Pearson's correlation coefficients were used to evaluate the relationship of spherical equivalent with macular thickness. These were the results. This is a pie chart representing the number of female participants and male participants. And this is the table number 1, where which shows the difference in macular measurements in terms of sex. Here, the thickness of total macula, central fovea, and inner region of the macula was measured in micrometers. In women, the total macula thickness was 234.16 plus or minus 1.65, whereas in men it was 236.52 plus or minus 1.14. And central foveal thickness in females were 184.76 plus or minus 1.20, whereas in men it was 191.43 plus or minus 0.94. And the inner region 261.68 plus or minus 1.38 in women, and in men it was 272.28 plus or minus 1.06. Table 3 shows differences in macular measurements in terms of age. Here also total macular central fovea and inner region thickness in age 18 to 22, it was 230.95 plus or minus 0.91, whereas in 23 to 26, the total macular thickness was 227.9 plus or minus 0.96, and 27 to 30, it was 232.7 plus or minus 0.11. Central foveal thickness for age group 18 to 22 was 189.6 plus or minus 0.83. 23 to 26 years, it was 189.6 plus or minus 0.97. And age group 27 to 30, the central foveal thickness was 189.7 plus or minus 1.15. This is the graphical representation of correlation of central foveal thickness with spherical equivalence. And this is the graphical representation of correlation of inner regional thickness with spherical equivalence. Discussion. Mean age of patients in our study was 21.25 years, ranging from 18 to 30 years. Females, 11 participants, and male 9. There was a female to male ratio 1.2 to 2:1, and female predominance was noted. And a mean spherical equivalence of minus 8.22 plus or minus 2.04 diopters was obtained in the study. Women showed significantly decreased retinal thickness in all ETDRS subfields. No significant correlation was found between macular thickness and age, and central foveal thickness had a negative correlation with spherical equivalence, whereas the inner and outer regions had a positive correlation. Conclusion: macular thickness changes with sex and the degree of myopia. Therefore, the study suggests that the refractive status of the eye can be a significant factor in affecting the macular thickness, which should be considered while evaluating other macular pathologies and glaucoma. Thank you.
Dr. Parvati, have you included patients with posterior staphyloma, dome-shaped macula, and all those things?
No, ma'am, we haven't.
You haven't?
No.
Since your criteria is patients who are having more than 6 diopters of myopia, so have you included these patients or have you excluded?
Excluded, ma'am.
Excluded. What are the OCT findings, common OCT findings you see in myopia? Can you be a bit louder, please?
Retinal thickness will be decreased, ma'am, in fovea, central fovea, when compared to the E-metropes.
Other than that,
Other than that,
Is there any case of myopic macular degeneration in our study?
Sir, I'm sorry, sir, I couldn't hear you.
Is there any case of myopic macular degeneration where the thickness will be very, again, still it will be reduced in your studies cases?
Macular degeneration as such, we haven't got, sir, any cases.
Or whatever the cases you have studied, degeneration was not there.
No, sir. Significant degeneration was not found.
Okay. Any other questions?
no, sir. Let's go to the next presentation.
Yeah, next one, Dr. Swati.
Let's go to the next presentation. Dr. Tejaswini.
Hello.
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 Tell me.
Good morning,
Yeah.
sir. I'll
Yeah.
share the screen. Sir.
Yeah.
Can I start, sir? Hello.
please start.
Hello. Okay. Good afternoon, everyone. I'll be presenting on ocular findings in a patient with Best vitelliform disease. Coming to the introduction, Best vitelliform macular dystrophy is the second most common macular dystrophy after Stargardt's disease. Due to allelic variation in the BEST1 gene, inheritance is autosomal dominant with variable penetrance and expressivity. and it might be even autosomal recessive as well. It is a slowly progressive form of macular degeneration. Usually begins in childhood or adolescence, but age of onset and severity of vision loss can vary. Characterized by atrophy of retinal pigment epithelium. Coming to a case attended to our OPD, there was a 5-year-old male patient had come to our hospital OPD with history of decreased vision since childhood. And ocular examination, the vision in right eye was 618 with no pinhole improvement, and the vision was left eye was 618 with no pinhole improvement. Anterior segment was normal, pupillary reactions are normal, and these are the fundus images of both right and left eye showing a macular region which was round and sharply delineated. These are the red-free images of both right and left eye. Coming to the OCT images, there was a subretinal, there was accumulation of material anterior to the RPE epithelium of the right eye, and OCT image of left eye was this. Coming to the EOG report, there was low Ardence ratio in both right and left eye, which was 1.36 in right eye and 1.74 in left eye. And ERG report was normal. The key points of this case was low vision and fundus showing round, sharply delineated macular lesion. The OCT images showing accumulation of material in the subretinal space above the RPE and below the outer segments of the photoreceptors. EOG was abnormal with low Ardence ratio and ERG was normal. Conclusion, our case highlights the ocular findings in Best disease and correlation of the fundus findings with the OCT features. Thank you.
What are the different stages of Best disease?
There are 6 stages in total. The stage 1 is a pre-vitiliform disease stage, wherein there is normal vision with only subtle RPE changes and abnormal EOG. Stage 2 is vitiliform stage with classic egg yolk lesion. And stage 3 is pseudo-hypopyon stage showing lipofuscin layering. Stage 4 is vitilo-eruptive stage with the breakup of the material, which gives a scrambled egg appearance. Stage 5 is atrophic stage with central RPE and retinal atrophy. And stage 6 is choroidal neovascularization.
Can you tell me what all stages is seen in your case?
It was stage 2, ma'am.
Okay.
It was a vitiliform stage with egg yolk lesion with mild vision loss, and EOG was abnormal.
Yeah.
What is the differential diagnosis?
Differential diagnosis, the pseudo-vitiliform macular dystrophies like adult onset macular dystrophy.
Then?
Pattern dystrophy of RPE.
Can you name differential diagnosis just by seeing at the OCT? You don't know whether it's Best disease or no. You have just seen the OCT. Can you name some differential diagnosis?
Adult onset macular dystrophy, ma'am.
OCT. Any other questions?
That's all. You can continue with the next.
I think we can wrap it up.
Yeah, Dr. Swati is there or she is not there?
So, yes, sir.
Yeah, then you start presenting.
Thank
Okay,
you.
sir, 1 minute.
ವಿಡಿಯೋ ಆನ್ ಆಗಿತ್ತೇನೆ ವಿಡಿಯೋ ಆನ್ ಆಗಿತ್ತಾ ಹೆಂಗ್ ಗೊತ್ತಿ ನೀನೇ ಮಾಡ್ದ ವಿಡಿಯೋ ಆನ್ ಗೊತ್ತಿ ಏನೋ ಬಂದಿಲ್ಲ ಸಡನ್ ಆಗಿ
Good afternoon, sir. Am I
Yeah,
audible?
continue. Continue. Hmm.
Good afternoon, sir. My topic is prevalence of anemic retinopathy and other ocular manifestations in anemic patients. And my chief author is Dr. Chaitra MC. So introduction, blood disorder constitute one of the main health disorder that presents with various clinical manifestations. Eye and its adnexa. The substrate required for retinal metabolism is decreased in anemia and renders it prone to hypoxic injury. Thus, anemia acts as an indicator for retinal damage, and the severity of the retinal manifestations depends upon the severity of anemia. So, objective of my study is to estimate the prevalence of ophthalmic manifestations associated with anemia and to correlate the various ophthalmic manifestation with severity of anemia. Materials and method. Study design, this is a hospital-based retrospective study, and study population, the data was collected from tertiary care hospital from previous records from May 2019 to May 2021 of the anemic patients. Sample size is 180. Inclusion criteria, patients more than 30 years of age with hemoglobin concentration less than 12 gram per deciliter in females and less than 13 gram per deciliter in males. And the exclusion criteria is patient with other retinal disorders and systemic diseases like diabetes or hypertension were excluded. Procedure, data was collected from medical records section, patient demographic data, the incidence of all the ophthalmic manifestations related to anemia and their association with severity of anemia was noted. And for the descriptive analysis, the categorical variables will be analyzed by using percentages and the continuous variables will be analyzed by calculating. So descriptive analysis of severity of anemia in the study population. Anemia was graded on the basis of hemoglobin concentration, and in the males 11 to 13 gram per deciliter. Less than 11 to 13 was taken as a mild, and in female less than 11 to 12 milligram per dl, and moderate is 8 to 11 per milligram per deciliter, and below 8 is taken as a severe. So in my study, more than 50, maximum patients are in the moderate group, that is 51%. After it severe, that is 27%, and then mild, that is 22%. So the ocular manifestation in anemic patient are maximum, most common manifestation is a conjunctival pallor, which is followed by retinal venous tortuosity seen in 19.4%, then retinal pallor, and then cotton wool spot and papilla edema. Whereas a study done by Jekyll et al., the most common manifestation is conjunctival pallor only, similar to my study, but that is followed by fundus pallor, retinal hemorrhage, and Roth spots. One more study done by Slot et al. In that study, the most common manifestation is conjunctival pallor, followed by retinal hemorrhage and fundal pallor. Comparison of the conjunctival pallor and disorder, it has been indicated that anemic retinopathy is reversible in most of the cases with rectification of the anemia. So regular fundus examination can help in judging the severity of anemia. Ocular abnormalities increases with the increasing severity of anemia. Hence, all the patients with moderate to severe anemia should go through thorough examination so that early diagnosis can be made and timely therapy can be given. My financial disclosure is nil. Thank you.
Did you determine the type of anemia in these patients?
Hello.
Yeah, did you determine the type of anemia? What type of anemia?
No, ma'am. It's just all the anemic patients are graded on the base. Yeah, that is the most iron deficiency anemia, and depending upon the HP concentration, I graded all the patients. 11 to 13 gram in male and 11 to 12 in female for mild, 8 to 11 moderate for both male and female, and below 8 severe for both male and female.
What are the other causes for rod spots?
Causes of rod. Sir, because of anemia, there is oxygen, there is a main substrate deprivation in the retina, resulting in the increased circulation in the retinal vasculature, and that might result long duration that might land up result in the rod spot.
Like other causes other than this anemia?
Diabetes, in diabetes, diabetic patients and diabetes, hypertensive patients, and hello.
Yeah. Any other questions?
No, sir.
No, sir.
Okay, we can continue to the next. Dr. Tanvi.
Hi.
Dr. Tanvi.
Yes, sir. Should I share my screen?
Yeah. Start.
Can you give me 5? Hello, sir.
Yeah. Tell me.
I'm not able to share my sir. Can you give me 5 minutes, sir? Or should I
Yeah.
present at the end?
Yeah, there is one more presenter, that's all. So we'll ask the other presenter. After that, you can present. Is it okay?
Oh, sir.
There is one more presenter.
Yes,
After
sir.
that, you can present. Dr. Vasundhara is ready?
I'm unable to share, sir. Can I take few minutes?
Yeah, that's what. Like, keep it ready. By the time you finish the other speaker.
Yes, sir. Yes.
Dr. Vasundhara?
Yes, sir. I'm ready, sir. I'm ready, sir.
Yeah, start.
I'm ready, sir.
Start.
Is it visible, sir? Is it visible, sir?
Yeah. No, make it full screen.
Can I start, sir? Hello?
Yeah, start.
Hello? Okay. Firstly, I would thank Karnataka Ophthalmic Society for providing me an opportunity to present my paper on macular evaluation in a ward setting, which tests I to rely on. So this was an observational study conducted in Vaidehi Institute of Medical Center department in the ophthalmology department for the duration from June to October 2021. So diabetic maculopathy, macular degeneration, cystoid macular edema are the leading causes of impaired vision in the developed and developing countries. In the early stages of macular degeneration, vision is usually normal and patients may be asymptomatic. But as the macular degeneration advances, the vision can become blurry and distorted centrally. Therefore, early detection of AMD is important to allow for an attempt to prevent the advancement of vision loss and decrease the morbidity. In recent years, many imaging modalities have been introduced for detection of macular disorders, which are accurate, which are more precise, like ocular coherence tomography, fundus fluorescent angiography, visual field perimetry. But in a developing nations like ours, most of the remote areas do not have the access to these advanced diagnostic tools and also not affordable. Therefore, this study aims at determining the most effective bedside tool in screening the macular disorders, which are easily accessible and easy to perform and also cost effective. So we used Sneller's chart for the assessing the distance vision and for the best corrected visual acuity, and near vision chart A near vision contrast sensitivity to test this Pelli-Robson chart was used. Slit lamp biomicroscopy to see the anterior segment as well as the perform 90D fundus examination and to grade the cataract. Amsler's grid test was also used, and OCT macula was performed, and fundus camera to document the fundus findings. So, inclusion criteria: all the patients aged between 18 to 80 of both sex attending ophthalm OPD for eye evaluation. Visual acuity was more than 6/60 was considered in this study, and of near vision more than N36, and the patients having normal mental aptitude to participate in the study and also willing to participate in the study. Exclusion criteria: any person who has any other ocular pathologies like significant cataract, corneal opacity, vitreous hemorrhage that which obscures the visual axis, or glaucoma which has the central scotoma, and myopia of more than 6 diopters and astigmatism of more than 3 diopters was excluded. Patients were subjected to routine ophthalmic examination along with various macular function tests mentioned above. For routine ophthalmic examination, the following tests were done: visual acuity for near and distant vision, and best corrected visual acuity was performed. Color vision was documented. For anterior segment examination of the eye, slit lamp biomicroscopy was done. And to assess the macular function, the following tests were done, like near vision contrast sensitivity using Pelli-Robson chart, Amsler's grid test using Amsler's grid, photo stress test, and OCT macula was performed. Macular changes were measured using macular function test, and these findings were compared to the OCT findings. Descriptive and inferential static analysis was carried out, and significance is assessed at 5% level of significance, and mild significance was considered when p-value was less than 0.10, and moderately significant when p-value was between 0.01 to 0.05, and strongly significant was p-value less than or equal to 0.01. So this was the near vision chart findings that was documented, and p-value was seen to be less than 0.01, which is again significant. Near vision contrast sensitivity had p-value of 0.006, which was very significant when Amsler's charting was performed, and p-value was 0.015. And photos test had a p-value of 0.012. And to conclude that, we can see that near vision contrast sensitivity was the most sensitive test when compared to all other tests, and also basic near vision can also give us the can help us in screening the macular disorders. And it was noted that Amsler's charting was very useful in screening for macular disorders with macular edema than without macular edema. So it can be used as a screening tool for monitoring and also assessment of the progress of the treatment which we use in the various macular disorders. Thank you. Thank you. Thank you. Thank you. Thank you.
Hello. Hello, sir.
Yeah, you're ready.
Sir, 1 minute, sir.
Yeah.
Which one?
Google Drive, the saved in Google Drive.
No.
Then go back. Basic. And then basic. Go to basic.
Screen.
Go. Screen. Now you press your
Hello, sir.
Yeah.
Is it visible, sir?
Yeah, it's visible. Make it full screen and then start presenting.
Okay, sir. Thank you. Hello.
Yeah.
Is it visible full screen, sir?
No, not yet. It has not yet become full screen.
Hello.
No.
Hello.
Yeah, still it has to become full screen.
Is it visible, sir, full screen?
It's not. It has not become full screen.
Dr. Tanvi, the PPT is visible. The first page is visible, but it's not full screen yet.
1 minute, sir.
Yeah, now it's full screen. Yeah, now it is full screen. Continue.
Okay. Good afternoon, sir. My topic is optical coherence tomography defects that invite disaster. My chief author is Dr. Vittal Nayak. Coming to introduction, optical coherence tomography is a useful, efficient, non-invasive imaging technique useful for identification of lesions in the macula, optic disc, and the anterior segment. Information gathered from the OCT can be qualitative, that is cystoid macular edema, macular hole, or quantitative data such as age-related macular degeneration and macular edema. Interpretation of this data in clinical situations must be tempered by the fact that images thus obtained are subject to artifacts which can mislead clinicians to wrong diagnosis and inadequate management. Knowledge about these artifacts in an OCT image will aid in better interpretation of the disease condition. According to the study conducted by Ray et al., had identified 6 types of OCT artifacts like misidentification of the inner retinal layer, misidentification of the outer retinal layer, out of register artifact, degraded image scan, cut edge artifact, and off-center artifact. The study was conducted to identify the common artifacts seen during OCT imaging in our clinical scenario. Coming to materials and method, this was a cross-sectional study. Proper informed consent was taken from each participant before starting the study. The study was conducted to detect the various defects that would be observed by performing OCT. Statistical analysis, chi-square test was used as test of significance for qualitative data. P-value of less than 0.05 was considered as statistically significant after assuming all the rules of statistical tests. Coming to results, a total of 83 patients were included in the study. The mean age of the subjects was 46.20 plus or minus 13.2 years. Out of this, 60 were males, that is 72.3%, and females were 23, that is 27.7%. In this study, 68.7% had normal OCT images. In our study, the highest OCT defects, that is 22.9%, had dry eye, 2.4% had refractive error, 1.2% had macular edema with epiretinal membrane, motion defects, retinal edema, edema of the optic nerve head, and vitreomacular degeneration. This is a table showing percentage of the various artifacts in our study. The highest artifacts were seen in cases of dry eye, that is 22.9%, second commonest being in refractive error, that is 2.4%, and the rest with 1.2%. Coming to conclusion, in this study, we concluded that among all the artifacts noted in OCT, dry eye was the most commonest artifact, followed by the refractive error. With the intention of minimizing the artifacts, the following lubricating drops like hydroxypolymethyl cellulose, carboxymethyl cellulose, and polyethylene glycol was instilled. Among the tear substitute used, polyethylene glycol showed the maximum improvement in the OCT signal strength. This is a OCT report of the picture showing the OCT report of the optic nerve head scan of a patient with dry eye, in which the color-coded retinal nerve fiber layer thickness map shows thinning of the retinal nerve fiber layer. This was after we instilled the tear substitute. The left eye was the initial signal strength was approximately around 3. After instilling the tear substitutes, it showed an improvement of a signal strength of 5. The right eye was normal. Coming to summary, Optical coherence tomography is now an integral part of management for numerous retinal diseases for its diagnosis, treatment planning, and follow-up. OCT interpretation must involve the understanding of the associated artifacts which can mislead the ophthalmologist to wrong diagnosis or inappropriate management. These were the list of references used in our study. Thank you.
What
Hello?
other artifacts did you
Hello?
get?
Sir?
What other artifacts did you get? Only in dry eye you showed that there's a variation in the thickness.
Yes, sir.
And in refractive errors, what are the artifacts did you get?
Sir, in refractive errors, there's usually like the choroidal thickness and the due to the increased axial length, sir, there was increase in the foveal retinal thickness and the decrease in the subfoveal choroidal thickness, sir.
Okay.
In case of refractive errors, sir. In case of dry eye, sir, there was thinning of the RNFL.
Okay. Okay. Thank you.
Thank you, sir.
Was dry eye diagnosed?
Sir?
How was dry eye diagnosed? Like before doing OCT, you known that the patient has dry eye, or how is it like?
Yes, ma'am. We had specifically taken patients with dry eyes for the study, ma'am.
In that case, you did the OCT before and after application of drops?
Yes, sir. Before also was done, sir. And after instilling the drops also, we had taken OCT images, sir.
Okay.
So similar changes were noted in all patients?
Ma'am, only with dry eyes we saw a signal strength improvement, ma'am. With the refractive error, there was no much of an improvement. Dry eye, there was a signal strength improvement from 3 to 6, ma'am. That is after instilling polyethylene glycol tear substitute.
Okay. Any other questions?
No, sir. Okay. It's been covered.
Okay. So we are completely.
Thank you, sir.
We have completed this session, that is a medical retina. So all the candidates have done well. So I thank the opportunity given by KOS for this session. So I'll also thank all the other co-judges for this session. Thank you. Thank you, Ananda.
Thank you. Thank you, sir.
Yes, sir.
Thank you, KOS, for the opportunity.
Thank you for the opportunity.
All the best for all the participants.